Hello, my name is Dr. Jenny Soanes. I'm an Associate Professor of Theriogenology or Animal Reproduction at LSU School of Veterinary Medicine. And I'd like to thank Louisiana Thoroughbred Breeders Association as well as Clear Creek Stud for inviting me to talk about pregnancy basics in the mare and to discuss when it goes right and when it goes wrong. And we have some pathologies that I think everyone's probably had some experience with, and we're going to talk about it in a little bit more depth in this seminar. Okay, first, I think for establishing any pregnancy in the mare, it's critical to have good communication between the stud operation as well as the broodmare manager and the veterinarian that's either treating the stallion or the mare or both to have a healthy outcome as well as a live foal at the end of the day. I think many of us that are in equine breeding management are very well versed in what it looks like when a mare is ready to be bred. And so here's just a video to illustrate, what that looks like. Again, that behavioral heat, which may be our first indicator that, time is of the essence. When a mare in the presence of a stallion is lifting her tail, seemingly receptive, posturing to urinate, etc. And then we know that our journey has begun. Nextly, you probably work with your veterinarian to perform a reproductive exam, which would include anything and everything, including a vaginal exam to inspect her cervix. When she's in heat, it should be open. And then transrectal palpation ultrasonography to look at her uterus and ovaries to be sure she's in the right state of estrus. And then once she is pregnant, transrectal ultrasonography is essential to examine the placenta serially to make sure there's no pathology or incidence of placentitis, which we'll talk about, as well as to confirm the fetus is viable at any point in gestation. And in equine practice, ultrasonography has become an essential tool, not only to determine the fertile window in broodmares, but also to determine pregnancy at the earliest stages, as well as fetal viability throughout pregnancy. So firstly, we use it for ovulation timing. We want to ensure that besides behavioral signs of estrus, the mare also has a dominant follicle, uterine edema, no signs of pathology in her uterus or any other parts of her reproductive tract. So we can ensure that she's bred and inseminated during the appropriate time frame, hopefully during working hours. We also want to establish that she's pregnant and be sure that she doesn't have twins, which is very common in thoroughbred mares. But we also want to perhaps use ultrasonography to determine if she's having a filly or a colt, which can be done at several different stages of gestation. And then again, we can use ultrasonography to ensure that she doesn't have signs of reproductive diseases, such as endometritis at the time pre and post breeding, or placentitis at any time during pregnancy, which would be deleterious to having a live foal. So we want to use ultrasonography and basically signs of estrus to determine the broodmare's fertile window. We can use signs of behavioral heat, like I showed in that video. We can also use ultrasonography to look for signs of uterine edema. And in this figure here that I've taken during transrectal ultrasonography, you can see the uterus right here that has this classic wagon wheel or orange slice appearance, meaning that the folds of her uterus have a lot of fluid and that it's edema, meaning she's in estrus. Now, she doesn't have fluid in the lumen or inside the opening of her uterus. We'll talk about that. This would be associated with a large pre-ovulatory follicle that we can measure with ultrasound at about 35 millimeters in diameter. And if we use vaginal speculum exam, we can determine that she has an open cervix. And all these together would determine that she is in her fertile window. Now, when she is in her fertile window, we make sure we don't see any signs of infection. And this is again a transrectal ultrasonography image. Instead of seeing that wagon wheel or orange slice, we see this black structure indicating fluid accumulating in her uterus, so it could be a sign of infection or endometritis. And ideally, your veterinarian would sample this for culture and cytology or examination of the fluid to look for bacteria. As your mare progresses into heat, so past beyond signs of behavioral estrus, using ultrasonography, we can look for changes in that preovulatory follicle. So this black circle here is the preovulatory follicle. And these different color changes with red and blue, we can see blood flow to that follicle. And as ovulation is pending or imminent, we can see that those blood flow patterns change to where she's going to ovulate. And that can indicate us that she's very close in her fertile window. And that can help us decide when she should be bred. So with normal ovulation, using transrectal ultrasonography, we can see this dominant follicle here. And you see it's a fairly nice spherical structure that then will deform. And it looks, I often say it looks like Texas. So it'll deform and then it disappears, right? So here where that dominant follicle was, it's now filled with hemorrhage. And that is indication that the follicle has ruptured and now filled with blood and that the mare has ovulated appropriately. So hopefully if she was bred before ovulation and she had a normal ovulation and her uterus is free of fluid or free of signs of infection, that approximately 12 to 16 days later, post-ovulation, we would do transrectal ultrasonography like in this image here, and we'd see something like this black circle indicating an embryonic vesicle or a successful pregnancy. So this larger circle here is her uterus, and this smaller black circle here is a fluid-filled embryonic vesicle. And then even if we're uncertain at day 12, we can look at a subsequent ultrasound exam, on day 14, that spherical structure has enlarged. It looks like it's growing appropriately, and it's healthy, and that this mare is bred. So what happens commonly in thoroughbreds is that they do have twin pregnancies, which is usually the result of 2 ovulations, so 2 eggs and 2 sperm. So just like in that ultrasound image that I showed in the previous slide, in this one, not only do we see 1 embryonic vesicle, but we see 2. And mares can have successful twin pregnancies, but it is uncommon. So as the veterinarian's role in assessing pregnancy at the earliest stage, we would elect to reduce one of these pregnancies. So we can manipulate them to separate like here and like here. And we can do manual reduction either with our hand per rectum or with the ultrasound probe per rectum to manually reduce one of those pregnancies. There is a chance that they will self-reduce. However, if they both persist, it is very likely that they will both be reduced and potentially, rule your mare out for a successful breeding season that year. So it is advantageous to detect them early, before day 16, and reduce a twin pregnancy to a singleton pregnancy. And in this ultrasound video that I'll just play for you here, this is a day 60 pregnancy, and it may be hard to fully appreciate, but this pregnancy is a filly, and I will try to pause it at the appropriate stage, but just I want you to see here how challenging it is, not just to see that there is a healthy pregnancy and there's moving, there's cardiac activity, but at this stage we can identify the genital tubercle, and in the filly it's going to be closer to the anus, and in the colt it's been closer to the umbilical cord. So let's see if we can pause it just right. So here's the back legs, and we're going to look for a structure right in the middle. You can almost see that structure starting to appear. That's going to be more prominent in the filly between her legs as opposed to the colt, which I think is in the next slide, closer to the umbilicus. So we have a viable fetus. And this is the umbilicus, and we're looking for a prominent structure near the umbilicus that, even for me, as I've seen this footage many times, it's still challenging to articulate. Umbilicus, and there's this little structure which is going to be the prepuce closer to the umbilicus. Now, as we progress into pregnancy beyond day 60, we look for other signs of pregnancy fitness or health. One of them would be the combined thickness of the uterus and placenta, or the CTUP. This is done by transrectal ultrasonography, and in subsequent slides, I'll show you how to do transabdominal ultrasonography. But essentially, we take measures of the uterus and the placenta, also known as the chorioallantois, just cranial to the cervix. So in this image here, we have the cervix, and we have the placenta as it abuts the uterus, and we measure that between these two X's. Our landmarks are that we want to be just next to this middle uterine artery, indicated B, and we want to be just next to this allantoic fluid, away from the amnion, indicated by A, and this amniotic fluid. And we know that we have physiologic edema, or thickening of the placenta, up here, so we don't measure that. But we want to take our measurements ventrally as they course downward, and we want to have serial measurements to get an average. We want to make sure that we don't incorporate the amnion, indicated by A here, because that will falsely increase it. And at this time, we can notice the echogenicity of the allantoic fluid here, as well as the amniotic fluid here, because it'll get more cellular or more bright white if there's presence of infection. So in this image, which is a clinical case, we're measuring the CTUP, and although it's flipped backwards, you can see the cervix here, the amnion here, which is the amniotic fluid here, the allantoic fluid here. This black line here is the artery, and so we take these measurements here of that bright white line. And the measurements of 2 to 3 millimeters are positively correlated with a healthy pregnancy in this particular patient. Another example of looking at a mare here, we have the cervix, the allantoic fluid, blood flow with the red indicating the artery, and then we're taking serial measurements right here in this white space, 4, 4, and 4 millimeters, which is appropriate for the stage of gestation. In this color flow video, we're looking at not the CTUP, but we're looking at the fetal gonad, which is this spherical structure here. And you can see using color flow, which is to illustrate the utility of that in ultrasonography and assessing the pregnant mare. You can see this pattern of color flow peripherally. Play it again. And then it makes like this little arc. And so in fillies, we have this peripheral blood flow, whereas in colts, we have a central blood flow. So in this one of colt, we have this, not ready to play. But we have this spherical structure here. And we can see this white line that if we had color flow would be associated with that central blood flow, indicating it's a colt. Okay, this ultrasound of a filly foal. Let's just orient you. This is the umbilicus. These are the two. This is one back leg. This is the other back leg. This bright white spot here is the beginning of an important structure. And see how this bright triangle gets bigger and bigger. And you can see two little prominent protrusions. That's the udder with two teats. And that, besides the gonads, the udder is also a positive indicator of a filly foal. All right, so we've talked a lot about normal pregnancies. Now we're going to talk about some Abnormal pregnancies, first, early embryonic loss, which is pretty common in mares. And if you do your first ultrasound exam between day 12 and 16, as I discussed, and she's open, question is always, did she get pregnant? Was she ever pregnant? Could she have been pregnant and she lost it? It's very hard to determine that. We also want to use those early pregnancy ultrasounds to determine if there's a twin pregnancy. And then abortion is not uncommon in mares, and that's something that we deal with in practice clinically very often. And then we have some uncommon problems of pregnancy like prepubic tendon rupture, fescue toxicosis, uterine torsion, and umbilical torsion. So firstly, if we have any problems with pregnancy, we try to classify them based on stage of pregnancy to help determine what was the potential cause. So whether it occurred in early, mid, or late gestation, knowing mares have an 11-month gestation. And then whether the pregnancy loss could be of a non-infectious origin or an infectious origin. So as a review to some, the placenta or the fetal-maternal attachment is diffuse, meaning that the placenta lines the whole of the placenta from cervix, uterine body, both horns, all the way to tips of the uterus. This interdigitation of the placenta in the uterus begins as early as day 25, and we have placentomes that allow exchange of nutrient oxygen material by day 150 of pregnancy. So that's why the very earliest stages of pregnancy are the most key to ensure pregnancy success. We need this fetal placental attachment to work in order for pregnancies to thrive. I'm sure a lot of us are familiar with looking at the equine placenta post-foaling and assessing these fetal membranes. So beginning in this image here with this whitish structure as the amnion. And once you open it up and assess it, you really, as I say, you should be able to read a newspaper through it. It should be clear and translucent. The cord here contains some vital structures, including the umbilicus, which is 2 uterine arteries, one umbilical vein, umbilical arteries, umbilical vein, and a urachus. And these are all essential for health of the foal. This opening right here is at the level of the cervical star, and that's where essentially the foal busts open the placenta in order to be delivered. And this placenta lines all of the uterine body, as well as the non-gravid horn of the uterus, as well as the gravid horn. And all that needs to be passed in order to ensure that we don't have retained fetal membranes. When it's passed, we look for areas of abnormalities, such as avillus areas, or areas of exudate or pus that could have interfered with nutrient oxygen exchange to the foal. And as you assess the pregnancy, it's a good idea to weigh the foal as well as the placenta, because the placenta should be about 10% of the foal's birth weight. Now back to our CTUP, our combined thickness of the uterus and the placenta. We have some published reference ranges for what that thickness should be based on the stage of gestation. So most people will do these assessments sort of towards the end of pregnancy, so the last 60 days or so. And so when we look at them at 9 months, it should be less than 7 millimeters. When we look at them at 10 months, it should be less than 8, and so on and so forth. So if we see any thickening, like in this measurement here, that could be an indicator of pathology or disease. And if there is colonization of that chorioallantois or placenta, especially near the cervical star, we can see evidence of what we call placental separation. In this image here, this is bacteria creating essentially a pus pocket at the level of the cervix. And you can see where the placenta has detached from the uterus. And even more so here, we see the cervix, and they should all be one straight, bright, white hyperechoic line. And now there's this separation, which is essentially pus. And so now the foal is deprived of nutrients and oxygen. When these foals are delivered, the cervical star indicated right here where the foal busts open, instead of being this nice red velvety texture, we see this avillus area that's white and pale. And so there was an interruption of nutrient oxygen exchange. And so this can commonly result in retained fetal membranes, which can be life-threatening to mares. And so you probably want to recover this placenta and potentially submit it for histopathology. You can also weigh it, as I mentioned before, but you can help get your diagnosis of whether it's bacterial placentitis using histopathology. Another type of placentitis, besides those that colonize at the level of cervix, is called a diffuse placentitis. These can be extremely challenging because this requires ultrasounding transabdominally or putting the probe on the mare's belly, which they often don't like. And then because of the nature of that big placenta, it can be very hard to find that little discrete pocket of where there may be pus or fluid accumulation. But if you're able to find it, that's something to monitor and to treat. In this image here, this is the skin is up here, the abdominal wall is here, and we can look at the placenta and measure it at this thickness. But like I said, it can be very hard to find that discrete structure that has some pathology to treat. Now, diffuse placentitis can be very, not only like I said, difficult to diagnose, but also to treat and to manage. In this particular case here, this is a broodmare that was 7 months pregnant and presented for colic. She required a celiotomy or colic surgery, and they had to open her cecum in order to relieve an impaction. And oftentimes just opening intestines and closing it can release a little bit of endotoxin or bacteria that can result in a diffuse placentitis. And so unfortunately, this mare, despite all medical management, progressed with her CTUP growing from 5 millimeters to 11 millimeters in a matter of days, and then ultimately aborted. And so these mares must be considered high risk for pregnancy loss and treated very aggressively. Another form of placentitis that can result in abortion is called nocardiform abortion. This is the result of a focal placentitis, or a very focal and fixed site of where bacteria may colonize. And we still don't know why this happens. This was first identified in 1986. And it occurs during the premature as well as the mature foaling season, anywhere from November to June, with its peak presentation between January and February. The etiologic agent is a bacteria known as Crossella equi, and other species have been identified. There is no age or breed predilection, and it's not associated with poor management, but it has been associated with a hot and dry fall prior to the foaling season, which I think we can all appreciate as far as this present year. Another form of diffuse placentitis would be due to cause to leptospirosis. The etiologic agent is Leptospira interrogans. Cerevar pomona is the most common one to infect horses, but there are other cerevars that can infect them. And it is zoonotic, meaning that it can infect other species, including humans. So you want to be very careful of environmental transmission. So a mare that has a lepto infection can be shedding in her urine. When she aborts, it can be found in the products of her abortion, and then that can contaminate feed and water and then propagate to other horses. This affects the fetus hematologically, so via the blood flow, it will cause a diffuse placentitis. The mare may have very mild, if any, clinical signs several days after infection, which could include fever, anorexia, and jaundice, and then abortion may present several weeks afterwards. Another cause of abortion, however uncommon, would be equine viral arteritis. It is an RNA virus that can result in outbreaks of clinical disease, albeit rare, occurring mainly in mares that can result in up to 50% abortion. There are some carrier stallions, so it's important to identify if the stallion you're breeding to is a carrier stallion that may infect your mare. If so, she may be deemed infertile, she may abort, but if she is infected, she's likely to make a complete recovery. These are contagious communicable diseases, so although the morbidity or death is low, it can affect horses upwards of 60% that then display prolonged immunity, and the breeds that are particularly vulnerable would be standardbreds. For all these itises and placentitises that we've discussed, your treatment modalities include specific things such as anti-inflammatories. Why do we use them? If it's a bacterial placentitis, we want to mitigate that immune mechanism or response to that presence of a bacteria that would cause release in inflammatory cytokines and prostaglandins that would contribute to uterine contractions and premature delivery. Typically, your veterinarian may prescribe something like phenixamelamine or banamine, phenylbutazone, or firecoxib, firecoxib has been shown to be superior when you combine it with antibiotics such as trimethoprim sulfa, and then progesterone supplementation such as alternogest. Toxifylline is another adjunct therapy that's been great to show that it improves blood flow to the placenta. It's also a free radical scavenger and somewhat of an anti-inflammatory as a phosphodiesterase inhibitor. Tocolytics are drugs that are used to keep the uterus quiet or prevent uterine contractions, clenbuterol being the most commonly used. This drug is a beta-2 agonist that can promote smooth muscle relaxation, and studies are ongoing to show its efficacy in the pregnant mare. A mainstay of therapy would be progestogens or drugs like alternogest, aka Regimate, whether it's single or double dose, to promote quiescence of the uterus, somewhat anti-inflammatory. And then as we get closer to having a normal foaling date, we're going to decrease that dose and taper it so that we can have somewhat of a physiologic foaling. Antimicrobials are often given broad spectrum because we don't have a culture and sensitivity to determine the causative agent pre-foaling. So if in hospital, potassium, penicillin, gentamicin may be given intravenous, or if on the farm, trimethoprim sulfa, which can be given orally. Both of those accumulate in allantoic fluid and hopefully will mitigate some of that bacterial growth within the placenta and the fetal placental unit. And then lastly, just to wrap it up, a couple of uncommon problems of pregnancy would be prepubic tendon rupture. In this image here, you can see this pregnant mare with this dropped abdomen, and you can see that she's got quite an enlargement ventrally with some edema. If you were to sample her mammary secretions, in this case, a prepubic tendon rupture would have some bloody mammary secretions, but in other cases of pregnancy pathologies where they have a big abdomen, they wouldn't have that, so that can be diagnostic. Fescue toxicosis is not hugely common here in South Louisiana, but for mares that are in Kentucky or bred somewhere else and then come down to foal, this may be something to have on your radar because ergot alkaloids can be present in endophyte infected fescue, so the hay. And then these ergot alkaloids produce a substance that's a dopamine agonist, and that results in low prolactin, prolactin being the hormone of milk production. So in those cases, we see increased gestation length, agalactia or failure to produce adequate milk, increased placental thickness, and oversized dysmature foals. And when we have placental thickness and an oversized foal, we could have abortion due to placental separation because then that foal can't bust through that thick placenta. Usually this presents in the last month of gestation, obviously, as we get closer to the end of the gestation length. And ideally, if you know if a mare is on fescue, you would remove her 30 to 45 days from foaling. If you can't do that, you would supplement her domperidone or a drug to antagonize dopamine so that she can make adequate milk in the last month of pregnancy. One of the last things to cover is uterine torsion, which is a twist in the pregnant uterus. This twist is usually cranial or before the level of the cervix. So the only way to tell if this is happening is to do a rectal palpation and feel for her uterus that's been twisted. It will present as colic at mid to late gestation, and your diagnosis is essentially made on history and palpation. The treatment would be Some have proposed putting flank in the plank, as you see in this image, where they put a plank in the flank to kind of stabilize the uterus, and they roll the mare around her uterus to correct it. However, because we know time is of the essence and that there's blood flow compromise to the fetus, at tertiary referral center, we would pretty immediately do a celiotomy or surgery to correct that twist to repair blood flow to the fetus. And lastly, umbilical torsion. So in any equine pregnancy, there's a certain amount of twist to the umbilicus that we consider normal. The foal is heavily mobile early in pregnancy, between 4 and 7 months. But if we see excessive twists, like here, where we see more than 7 twists, that could compromise blood flow. And if it happens acutely, you may see a normal size aborted foal that's recently lost blood flow. But if it occurred chronically, you may see a small or cachectic foal where they've chronically had deprivation of blood flow and oxygen. These vascular occlusions result in fetal death and autolysis, and it's hypothesized that it'll occur in fetuses that have a longer than average umbilical length, which is not uncommon in our thoroughbred pregnancies. So in summary, ultrasound is an essential tool of equine broodmare management. You can see an embryonic vesicle as early as day 10, but typically you'll do an exam from 12 to 16 days post-ovulation. The earlier the better to image potentially a twin pregnancy with 2 embryonic vesicles. By day 25, you should see an embryonic heart beat or rate with complete circulatory system. And then fetal sexing can be done in any of your viability checks as early as day 60 and even day 120. And thank you for your attention. I appreciate everyone being here today. And I thank the LTBA as well as Clear Creek Stud for inviting me to launch this webinar series. And I'm happy to take any questions anytime. And here's my email address to follow up with me. Thank you so much.